Hello, my name is Kazi Afrin. I'm a second-year internal medicine resident of Berkshire Medical Center, Pittsfield, Massachusetts. Here, I present a case of methotrexate toxicity in patient with cognitive impairment complicated by discharge medication discrepancy. So, methotrexate is most commonly used in the treatment of various malignancies and rheumatology diseases. High-dose methotrexate is associated with more myelosuppression, but low-dose methotrexate can also cause myelosuppression, especially in the setting of renal impairment, incorrect dosing and consumption, and co-administration with NSAIDs and other myelosuppressive agents. Myelosuppression is the major dose-limiting side effect of high-dose methotrexate, but is infrequent in patients receiving low-dose therapy with a reported incidence of 1 to 2% when used to treat rheumatoid arthritis. So here, a case of 73-year-old female who was admitted with dysphagia, mucositis, and painless macular rash on her face and upper trunk for a few days. Her past medical history includes dementia, Crohn's disease, and deforming rheumatoid arthritis for 40 years. Before this admission, she had a previous admission about 2 months ago with pneumonia, and there was a transition of care from hospital to nursing home to home living alone. On admission, she was on methotrexate, folic acid, hydroxychloroquine, and mesalamine. Labs on admission showed WBC and hemoglobin count went low. Platelet count was normal as shown in table 1. Hypersegmented neutrophils were present. Serum creatinine, vitamin B12, folic acid, and liver function tests were within normal limit. She eventually developed pancytopenia as her cell count continued to drop as shown in table 1 day 2 to day 8. She was diagnosed with myelosuppression secondary to methotrexate toxicity and was managed with leucovorin and colony stimulating factor, and she responded well. After discharge from the hospital, it was discovered that she has been taking methotrexate daily instead of weekly due to an error in the outpatient prescription written after discharge from the nursing home. So our patient developed pancytopenia with normal renal function and no concomitant NSAID use. Mesalamine is an unlikely factor as CBC remained stable after resuming mesalamine, and she had been taking methotrexate and mesalamine together for long term. The likely cause for methotrexate toxicity in this patient was an unintentional overdose resulting from taking methotrexate daily instead of weekly, resulting from an error in outpatient prescription when discharging from nursing home, which was complicated by her underlying cognitive deficit and by disruption of her routine upon the transition from hospital to nursing home and then again to living alone at home. So, elderly patients are at high risk for medication error in care transition. In a Swedish study, discharge summaries of more than 75-year-old patient with 5 or more drug medication discrepancies were noted for 38% of patients. In a Dutch study, which showed impaired cognition as the strongest risk factor for medication-related hospital admission. Another study found that participation of pharmacists in healthcare team conducting comprehensive medication review significantly reduces the risk of drug-related readmission. So in conclusion, this case report gives us an insight into the potential toxicity associated with unintentional overdosing on methotrexate. Patients with significant cognitive impairment, especially during transition of care, which disrupts their normal routine, are more vulnerable. Physicians and healthcare providers should be cautious about prescribing methotrexate doses weekly versus daily, given that both are used commonly. Pharmacist review and follow-up has the potential to reduce discharge medication discrepancies. Thank you very much.